All right, everyone. Well, welcome back to another episode of Claims Denied. If you're still listening to this podcast, I deeply appreciate it. Today, I'm super excited to be joined by Karoo Health CEO and co-founder Ian Koons. We're going to do something slightly different and not do the whole company spiel. I'm going to give a brief kind of history of Karoo Health to date. And Ian, I'd still like for you to, give a brief introduction. So maybe we can start with that first, then we can get into the rest of it.
Yeah, so appreciate it, Blake. Good to see you. I mean, I think at its core, Karoo really was or is the kind of leader for cardiac, kind of VBC enablement, right? We're really architecting what those contracts look like for our payer partners, managing that network and risk, but then really from the, kind of a bottoms up approach, right? I think one of the things that's fundamentally different in our go-to-market from others has been our desire and recognition of, who's really driving care and then the missing links historically, which has been take delegation work around the providers. And we have a fundamentally different approach of saying, hey, it's really the providers and the trust and the attribution flow is through the existing provider network. And then we're customizing the amount of risk that they take alongside of us. So there's a natural incentive and alignment. And then, we're customizing the solutions of wraparound services and technologies at the fingertips of our physicians and providers and payers to make sure that they can kind of be as successful. But it's not a one size fits all, understanding that healthcare is definitionally a cluster. And we are there to help in whatever capacity that we are. And so today, we're the largest kind of enabler in the country. We've got over 600, cardiologists, 11 states, 25,000, kind of lives. Happy to be here.
Awesome. Yeah. Thanks for that overview and super impressive. We've talked about the different kind of specialty initiatives across like kidney care and oncology. And now it seems like cardiology is kind of like the next growth vector, if you will, especially with kind of the level of activity there and interest in outpatient migration, those sorts of things.
It wasn't always that way, though. I think it's been the evolution. I mean, I think it's important to remember when we first started, both the payers, the providers really weren't, kind of interested in, value-based care. They weren't interested. And I think it wasn't top of mind. But fast forward today, I think we've seen the evolution of oncology, nephrology, and there's the importance and the spend cost downstream with the specialties. And I think it is cardiology's moment. In that fact, we really haven't done BD in almost 2 years. And we're really acting as a partner to architect what these contracts look like for our partners, which I think puts us in a particularly healthy position.
Okay. So that's pretty interesting. You haven't done any BD. So how have you kind of managed to shift the narrative around cardiology as a pretty traditionally, hospital-based employed model and move toward that kind of more, value-based care, like technology enabler approach?
Yeah, so I think it's fundamentally, there's two, from a macro perspective, two things really fundamentally shifted. I think from a payer perspective, you have the market pressures, right? I think that the additional MedX exposure from a payer perspective, I think they're getting, and they, meaning the payers, are having infinitely more pressure to perform relative to, kind of across markets. And that's been reflective of, the earnings calls recently. And as a result, they're looking for partners. But, ultimately a lot of these payers, and there's fantastic payers out there, but a lot of these payers do have, internal kind of constraints in the ability to architect and administer some of these programs. And cardiology is that. And so being that, we're trying to be collaborative partners and saying, hey, it's not just come in, here's the contract and you go through it, but what does the contract framework look like based on a particular market that is going to be able for us to manage costs relative to kind of what we're guaranteeing. And then I think on the provider side, it's important to say where we started. Like, I don't know, we've had many conversations over the years. We actually were going to start to be a de novo cardiac clinic. And it was our intention to go build de novo cardiac clinics and take risk so that we could prove the model, because ultimately we didn't think that the market was ready and cardiologists were ready to, kind of embrace, value-based care. And I think fast forward, what kind of transpired was ultimately you had a subset of cardiologists that ultimately went to their payers and said, I'm working infinitely harder. There's a compression of rates. I don't have the tools. Like, how am I going to do this? And when they said, do you have a partner, a technology partner, an enabler to help you through this? They said, what is that? They Googled, and I think we were the only ones that, had a website at the time. So fast forward, that was kind of the accelerant to us providing this, kind of model, as opposed to continuing down the path of a, kind of de novo build, more office-based approach. And it allowed us to accelerate our, kind of model that we largely deploy today.
And on that note, it seems like more cardiologists and physicians in general, the economics of a practice are struggling with professional reimbursement declining and those sorts of things. What's the typical kind of cardiologist makeup of somebody who would join your network? Like, is it somebody who kind of doesn't want to be hospital employed, wants additional earnings through your platform, or kind of what's your value prop and what's kind of the dynamic there, if that makes sense?
Yeah, so I wouldn't actually put it in a bucket, Blake, as far as like, is there an architect that typically goes with us? I think it encapsulates cardiologists and physicians definitionally are trying to solve for a multiple, kind of things, right? So if you break it down into the most simplistic view, time or money, right? Or both. And so, like, how do we provide those tools and technologies to either, hey, free up you from a time, so, that is the valuable, the most valuable commodity? Or is it, hey, how do we do this from an accelerant? So there's a financial opportunity and stability where there may not have been in the future. I think that's how we deduce it. And we do that through, the customization of the services that we're ultimately offering.
Yeah, that makes a lot of sense. And maybe that's a good segue into, the Karoo Health business model and what exactly you provide. So, you talked about you take risk and you work in a number of states with a number of payers. You most recently announced your Humana partnership. Congratulations on that. I think that's very fresh at the time of this recording.
Thank you.
And maybe we can dive into that a little bit, but also Zing Health. And you've also stood up a new kind of AI enabled platform. So maybe kind of like walk me through those, value props and what levers you have to, maybe increase value for the physicians and for your partners.
Yeah, I mean, so listen, if you think about the high spend, is the payers are trying to say, like, how do we have, a partner who's ultimately the single source of truth for cardiology, right? That can manage network, guarantee savings and spend, and provide that connectivity at the market level, right? And so what we're doing is we're adding those virtual capabilities through partners like a Heartbeat Health to expand the number of members and access that we can offer to a plan. We go in and, I think we're deploying those engineers and those, solutions based to say, okay, hey, is this opportunity where we can shift site of service in this to drive value? Is this I'll say emergency room opportunity, or, is the makeup of the population in which we're servicing an opportunistic and largely from a medication and management, right? And so you think about those buckets and then ultimately providing the best consumer experience that we possibly can. I think one of the things that we often do as startup executives and is default to the business models that are payers, providers, but ultimately I think the most important thing here is the consumers and the patients, the members, right? It's important to say that like we're doing this all for them, right? Because the end result is for them. And oftentimes these people have been kind of left their own, kind of life to manage congestive heart failure or, one of their chronic conditions. And for the first time in their lives, it's the physician telling them, hey, we've partnered with Karoo. We're going to give them all those tools in a way that's customizable for them. And that's ultimately when you think about like where we're going. I think we as an industry have built consumer products and products that are just like, how do we put it in a workflow and automate this specific thing? But definitionally, healthcare is super messy, right? So how do we think of like, you can be streamlined, but ultimately flexible within, these parameters of grabbing, hey, I actually do have this SDH, or I actually do have, food insecurities, or I do have certain comorbidities, and then tying that to the care plans laid out by the providers and putting it all together. And it ultimately creates this wonderful thing where we've had unbelievable success. I think we're still diverting about 30% of our panel from at least one ED visit, kind of regularly. We're having, best in class NPS scores, but it's an iterative process. It's not perfect. We need to get better, but with the accelerant of kind of AI and technology, it's been able to customize and personalize those experiences for our patients that we're going to continue to do.
That's awesome to hear. Yeah, super, super cool. And you touched on a number of things. I think the first thing I want to ask you about is around kind of, you mentioned automation and consumer experience. In your opinion, or in practice, where have you seen AI kind of be the most impactful? Like, what have you been able to automate, or what are kind of the areas that you're kind of honed in on?
Yeah, I mean, I think it's one of those things where I think as an industry, and it makes a lot of sense. We've been, the overwhelmed by kind of AI in general, right? I think how many podcasts have you talked about that everything is AI? It's probably nauseating.
Maybe everyone.
Every single one. And I think we're taking an opposite approach to that and saying like, hey, like how do we become that solutions-based, company where we're deploying, kind of engineers and teams to build and create value from within in terms of that baseline, right? And so like it may at some practice be they're having a really hard time automating, kind of that, where the best site of service from an ASC is, or, hey, that connectivity from an appointment is, and like, how do we become that value add? I think what you've seen within AI just more broadly is, I think the administrative results have been, kind of more instant, or from a productivity perspective, it has made sense. But I mean, I think we take a different approach of saying like, we're not going to deploy AI and resources for the sake of deploying AI and resources. We want to be very thoughtful about it, but where that biggest kind of J curve and the upside is that in the resources that we deploy.
Makes sense. Love that approach. And, something else I want to ask you within that kind of realm as well, especially on the payer side. We talked about payer woes. I think somebody recently mentioned to me, managed care actually has to manage care now, right? Kind of thing with the current state of MA, and not to poke fun at them or your partners or those sorts of things, but would love to talk about, one, how do you define value-based care, and two, how are you thinking about Karoo Health as it shifts from like value-based care as the industry kind of defines it into this more kind of, high value care approach?
Yeah. So, I mean, listen, I think there's a million definitions of what value-based care. You're going to hear something about, paying for outcomes and paying for, instead of volume and all of those things. I think in its most simplistic term, it's just an alternative payment model. that's the way that I kind of define it. And then, kind of there's levers and things around that payment model that you have to deliver against.
Okay, fair enough. I think that's pretty draconian, but fair, absolutely. And so maybe the second half of that question, we've touched on it quite a bit. Kind of consumer experience and those sorts of things, and being more of a technology partner and deploying engineers. But can you kind of double click on those concepts around?
I mean, listen, I think it's one of those things is that like for VBC companies, historically, you're either on two sides of it, and they'll definitionally call themselves value-based care, right? I think you have the one, which is why we're the payers specifically, and a lot of these companies are struggling, is a result of V28. They can't risk adjust their way to profitability anymore. Like, right, that used to be on the revenue side, and they didn't really care about the expense side. I think there's more pressure now that you can't just risk adjust your way to profitability and get to where it is. And so what that has done is shifted the, as you say, from the payers to care. But really what it's done is it's forced the payers to reevaluate what organizations they part with and what value they actually create, right? And I think what you've seen collectively is historically we've delegated, or those entities have delegated to, at-risk PCPs. I think what you've seen is that most of the cost and the expenditure is downstream with the specialists, right? Which is nephrology, oncology, and certainly cardiology. And so I think what you're seeing is kind of saying, okay, we should probably not segment those things, but how do we encourage models, collaboration based on that particular payment, right? And so I think, CMMI has done a good job in terms of at least putting that out there in access to say, like, how do we incentivize via technology as opposed to just volume, but then incentivize that collaborative nature to drive ultimate, kind of outcomes and savings against any kind of baseline, total cost of care deal.
Okay. Yeah, that makes a lot of sense. And since you mentioned access, I feel like we should talk about it. And maybe we can talk about just kind of payment policy in general, which is, everyone's favorite topic. But what was y'all's reaction to kind of, the rates that were put out there, the general model design? How are you guys as maybe folks who might be better positioned for something like that? Are you thinking about participation in it? What's kind of the approach?
Yeah, so my initial reaction, I think there's a lot of skepticism, at least early on, like rates. And I tend to not care about that, right? In terms of like, hey, like this is the first and an innovative model that Abe and Jacob and them have put out. And it's like, how do you provide that framework? And then it's that learning and iteration of the model that ultimately becomes successful relative to how it is now. I mean, again, I would severely doubt that anything is perfect, but I think I actually applaud them for, kind of thinking a little bit outside of the box in terms of kind of a siloed, kind of models that we've previously created. Like you have a nephrology model, you have an oncology model. And now I think it is at least incentivizing a more collaborative, kind of interaction and care between all specialists and stakeholders. And I think that's ultimately what you're going to see. Like there's a very big deal that we are participating in that is unrelated to access, but just actually more on the, kind of, I'll say, private side, right? And what we've done is kind of put together those key stakeholders of oncology, nephrology, at-risk PCPs, and kind of collectively gone and said, okay, like how do we guarantee a savings based upon this population? But what it does is it really does incentivize that collaboration because everyone knows there's no more pride of ownership. I think historically what has happened because of the way the dollars flow is you've had at-risk PCPs been apprehensive or, even sometimes hostile of saying, hey, we're not going to work downstream because anytime we do, we're billed, we are in a VBC at-risk contract. And when we send it downstream to fee-for-service providers, the incentives aren't aligned. And I think taking steps. And so the way that I think about it is, everything is definitionally imperfect, but how do we take steps to, kind of learn, and what's the framework that ultimately leads to something that's, innovative and successful.
You kind of mentioned this private initiative. Is this kind of something that's upcoming that you guys are working on, or has this kind of been happening?
So it's none of this is live. So that's what I'm saying. We're in the early stages here,
okay.
But giving you, kind of an example that also kind of goes along with similar ways of collaborative specialty care that CMMI is thinking about and kind
right.
of.
Like this is what a lot of risk-bearing orgs and other folks in the industry and with these various subspecialty groups or populations are thinking about, like with private payers. Like payers are more interested in collaboration, is what you're saying.
Yeah, I mean, listen, I think nobody wants to do 70 different deals, right? Anymore of like, I'm going to do a nephrology deal, I'm going to do a cardiology, I'm going to do PCPs. It's like, okay, how can we have a single source of truth, the RBE from a cardiology, nephrology that manage that whole thing across population, guarantee savings, and then have the collective toolkits to, be successful.
That makes sense. Yeah. Can I ask you a very theoretical question right now?
Absolutely, because I love theoretical questions. Right?
Not to put you on the spot, but I just had this thought around like, okay, you have like kidney care and oncology groups, and you guys, let's say there's this future where all of those specialized models working with various populations like come together, and they're now this consolidated entity. They're so good at managing diseases across various, disease states, chronic kidney, and those sorts of things. If that future comes to fruition and we see like kind of consolidation, what then becomes the role of the payer, if that makes sense?
So I'm gonna take it a couple ways. I think to answer it, I don't think it ever becomes a truly consolidated entity, more of a collaborative understanding of, here's our superpower. Our superpower today is understanding everything a cardiology within the cardiovascular realm. Right, definitionally. Nephrologist, greatly different. You also have to understand nephrologists and cardiologists. Historically, there is a certain dynamic there, right? That a cardiologist is never going to go work for a nephrologist, certainly at scale. So you're never going to have that consolidated kind of group. But what you will do is kind of say, the payers playing the role of forcing the hand and saying, hey, we're no longer distributing 16, 70, whatever it is, different kind of contracts on the subspecialty, but it's more of a participation in a global model, right? And you can, because you are the superpower and spike within your specialty, participate and manage that risk in collaboration with everybody else, right? And so I think what it ultimately becomes is that the payers get more comfortable with that the savings are there, that the patients, more importantly, are getting cared for, right? And then they move more towards that particular model over time, assuming those things happen, right?
Yeah, that makes a lot of sense.
Not different. It's not different than it is now, where a payer is gonna delegate the risk to a risk bearing. It just means they're delegating to fewer people in a more collaborative, defined model that you're constantly iterating.
Yeah, that makes a lot of sense. And I think that maybe the broader question I'm getting at is that, especially with how managed care has kind of played out economically over the past couple of years, a lot of people are maybe questioning what is the ultimate role of the payer, right? And they do certain things like the aggregate risk, and but on the other end, there's the denials and the utilization management. And so if you have all of these smart groups that are already able to handle all of these, specialized populations, then is there a world where there isn't a payer anymore, right? Or like, maybe the government is handling that function or those sorts of things. Does that kind of make sense, or is that too kind of myopic?
I think it's a little bit myopic in terms of this. I think it ultimately doesn't go to there's any payer because you're managing it so well, but I think certain functions within kind of what they do may obviously, like I do think assuming those models are, theoretically extremely successful in managing, kind of risk, but ultimately driving down those costs, right? It probably looks similar to, you don't have as use case for as much, right? Because it does you're managing total cost of care in a way that you don't have to go and say we're going to deny every claim and play that game. You're not, right? Because what you're doing is you're betting that if 5, 6 of the most innovative, technologically forward companies aligned with physicians are going at risk, and everybody it has all the tools, understands all the other stuff doesn't matter, and so it becomes obsolete, right? I mean, that's ultimately, I think, in the future state on if you do your job well, that is ultimately what it morphs into some kind of some form or fashion.
Yeah, so maybe the role evolves over time, similarly to how we're talking about value-based care kind of evolving away from a financial function solely.
Yeah, it'll evolve just like everything else, but I think there needs to be that force function. I think from a CMMI to say here's a framework that's forcing that, and then the people who are able to innovate within that are the ones that are ultimately going to be successful.
Yeah. And kind of on that note, around CMMI and payment models and those sorts of things, now you guys talk with policymakers around design and those sorts of things. If you were able to design your own model for cardiology or physician practices or whatever that looks like, what are the kind of things that are limiting you today? Like, how would you ultimately want that to be designed?
Yeah, I mean, listen, I think for specialists, for cardiology specifically, there's not a cardiac model that exists today. There is for nephrology, there's oncology. And so for cardiologists, I think it's because they've never really participated in a lot of these programs because there hasn't been, they don't understand, okay, there is this thing called policy and a model that exists that I participate in. And so, for us, it's how do we be the accelerants and prepare for the models that CMMI are ultimately putting out to prepare them for those models that they've never seen before, right? Like they're going into the jungle that they've never been in the jungle.
So are you anticipating, as CMMI continues, their trajectory in the 2030 North Star and those sorts of things, are you anticipating a cardiology specific alternative payment model, or will it be more so in kind of some sort of global category that you guys kind of capture a certain carve out of that? Does that make sense?
I think that's a really good question. I think our intention early on, and this may be wrong, Blake, because God knows I'm wrong every day.
Same.
Just ask my wife. So I think one of the things that, like, when we initially started spending significant time on, Capitol Hill with legislators and CMMI, our initial intent was actually to how do we be the architect of a cardiac model? And I think that as we've kind of gone through, not only from a policy perspective, but actually just an actual practice, a specific cardiology model may limit kind of a very specific viewpoint and not the right ultimate model. And so, I think what we're trying to do is saying, okay, like, how does cardiology as a whole play into and be an accelerant overall to the collaborative specialty models in collaboration with, kind of PCPs overall, right? And like, how do we put it together? And then within that, is there a specific lever that cardiologists are uniquely suited, to deliver on excess value? And if there is is there specific legislation about that you basically add to an existing model that, everyone is, financially, but also really from an outcome perspective successful.
Yeah. Yeah, that makes sense. And maybe like more specifically, is there anything within those categories you've identified, or is it kind of just all, hey, this is the high level design, and we'll get to the details later.
I think it's high level. I think there's some specifics that I'll leave for another day. But I think it's probably best from a high level.
All right, you'll just let me know when those specifics get announced, right?
I will for sure let you know, Blake.
All right, sweet.
You'll be my first text and call.
And speaking of things yet to be announced, I do understand, this is still on the DL, but you have signed a term sheet. Is that correct?
Yes, word got out. So
I'm everywhere. You can't escape
Blake,
me.
You are everywhere. Yeah. So listen, we are. I've signed a term sheet with one of the leading investors. I'll say kind of a legend thus far, putting together kind of a substantial round that kind of allows us to really grow and scale, add the payers, but then also kind of the talent, and then allows us to further experiment with offerings across the kind of what we're doing, and so we're really excited to partner with this firm, and take Karoo to the next kind of meaningful milestone in kind of the North Star of continuing to be kind of America's cardiac solution.
That's awesome. And, congratulations. I know that can be a grind. So looking forward to seeing that officially announced sometime in the coming months. So I am curious, just as a, CEO of Karoo and this next phase, you mentioned talent, you mentioned, obviously adding customers and those sorts of things. How do you think about kind of just, I don't know, maybe this is more of a CFO question, but like, capital allocation between those different strategies and growth and so forth?
You're gonna have to ask my as far as co-founder, but listen, I think it's ultimately we had an offsite yesterday, and a lot of that conversation revolved around kind of a relook on resource allocation, right? Like based upon what we know today, and then where we want to go. Like how are we allocating those resources to meet kind of the goals, but then ultimately, does those resource allocation, kind of hinder what we're trying to do in 2-3 years, or does it hinder what we are trying to accomplish today? And so, I think we are, from a talent perspective, there's a balance between functional area, but I think what we're really at least I am most focused on, is how do we attract the best talent in the world, and build the culture in which we're trying to build, right? We're very much a performance-driven culture, and we love people, or actually seek out people that have had, kind of have to overcome adversity, had, troubled childhoods, weren't just kind of the kind of the standard path that you would see from a pedigree perspective. And then ultimately, kind of it's the mission, how do we attract those mission driven people as opposed to the mercenaries, right? I want people that they feel deeply connected. Most of the people that actually work at Karoo, their families, their moms, their dads, their cousins, grandparents, somebody has had, more often than not, a cardiovascular event. So for them, this is deeply personal. And so, it's all of those traits that's most important to us, and that, they want to do this more than anything in the world, as opposed to, they don't want to sit and, whiteboard an app or something. Right. They want to be here building with us and continuing to live the mission that we're trying to accomplish.
Yeah. I love that. So you're after like, the scrappy, independent, like bring your lunch pail to work folks. What's that Will Smith movie where he gets like the stockbroker job?
I just watched this with my son, and I'm blanking on it
Dang
because
it.
I will. Let's revert back. You're gonna have to look it up on what it is.
The Pursuit of Happiness. I just
Pursuit of
Googled it.
Happiness.
Just
There
Googled
you
it
go.
live. Yeah. What a great movie. What a great movie.
Fantastic, fantastic. I mean, I
Um,
think that's emblematic of just like what that struggle you're willing to go through for ultimate success and for your family and for your loved ones in the future. And I think like when you have those type of people constantly working together, I think fantastic, kind of generational things happen. And I think that's what you've been seeing live, in the public with, how fast Karoo has, kind of grown. And I say, what are we, a 5-year overnight success? Because they haven't seen the years of struggle and pain.
yeah.
But,
Yeah.
I think people are starting to see nationally, all of, kind of the learnings and the team and the talent together. And we've been able to, produce those, fantastic things.
Do you think that's one of the primary things that distinguishes Karoo from another, potential peer just in the cardiology space?
Yeah, I mean, listen, I think there's a lot of entities, cardiology, nephrology, and I think they tend to follow a very predictable path, right? Of who they hire, where they come from, and the outcome has been, yeah, I think digital health we've all seen has been plus or minus, and I think in order to create those outsourced or outsized, kind of outcomes and truly do something, you have to be willing to do things and see things a little bit differently. And we see things a lot differently. And so it doesn't mean that we don't hire healthcare people. That's not true. But those healthcare people that we have insights that, go beyond a traditional, firm. There's firms out here that like we don't hire from. Because we don't want, I think we have an internal mindset, right or wrong. If we hire all these people from places like I'm referring to, you end up like that. And that's not what we're trying to do. And so, we try to, beat to our own drum a little bit compared to, I think, most and the people who are privileged to work here, like, a little bit different. And, they all are super, super talented. And I'm, it's a pleasure to work with them every day.
Yeah, no, I can 100% respect that closely held belief. You stick to your guns and, yeah, for better or worse, it seems to be working so far. So,
so far, so good.
Yeah, that's awesome. And so on kind of the note of talent and leadership and company culture and those sorts of things, you guys recently hired some new executive leadership, correct? So one, I'm curious, did you go through a similar process there? I assume you did. And two, how did you know it's kind of like the right time to bring those folks on?
Yeah, I mean, so listen, I think our leadership team, I'll put against any leadership team in the country. And I think the industry has largely recognized the talent, and we have to produce, God knows we have to. But we, have brought on, one of the most kind of innovative CTOs that we know that some people don't know, but is deeply respected within Silicon Valley, has built unbelievable things that, again, sees things a little bit differently than, everyone else. And, our bet is that the outcomes and the products and the engineering talent that we recruit reflects that, and then our new kind of network head, has been actually. So he's come from the more traditional path of, kind of payor innovative startups, but always, kind of candidly had a little chip on his shoulder. And I think it is one of those things that's been reflective of, the early success that he's had. This is also one of the only people that I've known for a really long time. And so if they're going to have a certain kind of, I'll say, pedigree, there's the certain personal, trust factor that, we have to have.
Yeah, I love that. Makes sense. As we're talking, I'm just like noticing this common thread of like, you're maybe a little non-traditional, or like you go about things in a different way, but things that you believe, are your way, right? And the way you think will ultimately lead to success, which I respect a ton. So I'm curious, what is something like, you or a Karoo Health as a whole like believes about healthcare, believes about running a company that maybe a lot of people don't think? Maybe there's something contrarian.
Contrarian. I mean, listen, I think that we have a long, Blake, how long do we have? I think this is probably another podcast, right?
I'm good all day, baby.
This is probably another podcast. But I mean, listen, I think there is, for us, we fundamentally believe that you have to run, have your superpower within that small niche or, larger niche like a cardiology, nephrology, right? And we find it kind of laughable if, you see some of these groups, candidly, that, are oncology, nephrology, PCP, trying to, pretend that that's a reasonable path for publicity that, I think we, fundamentally, contrarian, don't think that that's ever going to be a sustainable model rather than just a VC play.
That's fair. And, okay, so that sparks another question. How do you reconcile venture capital funding in a space like this, which comes with incentives around, J curves and high growth versus the friction and like the day-to-day blocking and tackling of the healthcare industry?
Yeah, I mean, listen, I think it's aligning. It's making sure. I think that not too dissimilar from, I'll say, venture capital at large, right? There is those pressures to have that J curve, to grow really fast, which we've seen to the detriment, especially in healthcare, right? Like it's not the same. But I think ultimately, like, it's less about venture capital and ultimately who are the partners that you're picking, right? There's certain VC firms that we all know I stay a million miles away from, even though they reach out every day. And I just won't do it, right? Because it is one of those things that they're going to incentivize you to, do habits naturally, or, kind of focus on certain things that, are detrimental to the overall sustainability of the organization. And so, ultimately it's deduced down to, do you want to be in the trenches for 10 years with this individual? Do I want to call these individuals at 2 a.m? Do they care? Right. That they're not on, 150 boards or whatever. So like, those are kind of the way that I think about it, but you're thinking about it as an accelerant, but understanding too, I have a little bit different viewpoint on take the capital that you need to hit the milestones that you are with, the calculating the dilution you're going to take and how much that capital cost, because there is a dramatic cost to the capital. And then it's just how to think through that, where I think what you'll see and have seen in recent funding announcements, there hasn't been well thought out, cost of the capital is way more expensive than the capital raised.
You mean to tell me that open evidence is deploying capital too fast? Is that what you're saying right now?
I actually think open evidence is
I'm just teasing.
But yes, there are others.
Yeah. Well, that's awesome. That's really good perspective, and quite a far cry from the post 2020 era where everyone was raising money, especially in value-based care, and kind of money was falling from the sky. It sounds like you guys have taken a much more kind of intentional, thoughtful approach around like, hey, here's what we're modeling, here's our objectives, here's why I want an equity for myself and for my team and whoever, and this is what it's going to take to get there. Is that kind of more or less how you see it?
Yeah, absolutely.
Yeah, very cool. Okay, Ian, would love to wrap up with, besides the upcoming funding announcement, which is exciting, what else should we expect from Karoo in the near future and the far future?
I mean, listen, I think you're going to see several announcements of kind of major deals nationally, with some of the big payers, innovative deals. I think you're going to continue to see kind of our team and the innovative things that we do, and you're going to see people following kind of what we're doing. And if you can kind of draw the correlation of what we do, where the kind of followers go, and that, it's the continuing, we will continue to kind of iterate and try to, do the best that we can for, our patients, providers, and ultimately kind of partners.
Love that. Well, I'll definitely be following along. And now that we've got all the healthcare stuff out of the way, I've got one final non-healthcare question for you. I like to wrap up every podcast. All 8 that I've done so far, how many it is.
How many have you done, Blake?
Something around 8. I like to think I've done more because I've done a lot of, virtual events and other things in the industry. But
the virtual events that you try to get me to go to.
Exactly. Yeah. Yeah. If anybody's listening to this, please sign up for all of my virtual events. It really helps me out, including you, Ian.
Yeah, for sure.
But yeah, so what I wanted to ask you is, what's a non-healthcare, piece of content or book or anything media related you've consumed that's changed how you approach your life?
So interesting that you say this, right? Like, so I think about, as we take this funding, as we're going through this growth period, and I'm actually rereading Marcus Aurelius meditations, just from kind of the stoicism perspective of kind of focusing on what's most important, and so I think that's helped level me a little bit, and my wife would probably agree. So I think that's one of the things that I'm doing. And then I think one of the things that I've maintained and always done, which is just, I have to, is I get up at 4 a.m. every day, no matter what, to work out. And, so that is one of, kind of the non-negotiables. I think that's helped me at least stay as centered as I possibly can.
Okay. So you and Mark Wahlberg are just up at 4 a.m. at the same gym, right?
Exactly.
Nice. I love that. Ian, really enjoyed our conversation today. I'm, again, looking forward to seeing everything you and Karoo do in the near and far future, and wishing you guys success in 2026. Thanks so much for being on.
Blake. Thanks for having me.
All right. Thanks.